Subpalpebral lavage system placement. The objectives of this video are to demonstrate the placement of a subpalpebral lavage system in the horse. Subpalpebral lavage systems are specialized ophthalmic catheters that allow the administration of topical liquid medication by injection through the lumen of a long tube that runs from the base of the neck to the eye. Medications are delivered to the ocular surface via a silicone footplate that rests against the conjunctiva. Ocular lavage systems may be constructed by the clinician or purchased commercially. In this video, we are using a commercially available subpalpebral lavage system. Commercially available systems are supplied with a sharp 12-gauge solid metal insertion trocar swaged onto a length of 5 French silicone tubing. Other items that will be required for placement of the subpalpebral lavage system include a sedative such as Detomidine, lidocaine or mepivacaine for local anesthesia, topical anesthetic eye drops such as proparacaine, diluted povidone iodine solution, sterile gloves, a needle driver, a headlight or focal light source, a male catheter cap or PRN injection port, white adhesive tape, 4x4 gauze pads, 1/0 non-absorbable suture inserted into an 18-gauge needle or on a cutting needle, tuberculin syringes and 3 ml syringes, and 25-gauge needles. Subpalpebral lavage systems can be inserted into the fornix of the upper eyelid or the cul-de-sac of the lower eyelid. Some clinicians favor the lower eyelid site because the nictitans prevents migration of the footplate and subsequent complication from footplate contact with the cornea. Others prefer the upper fornix because of the simplicity of securing the tubing to the face in a straight line toward the forelock. Preparation for insertion requires the following. First, the forelock and mane are braided. 1 forelock braid and several braids in the mane are required. These are secured with rubber bands or tape. The tubing will be threaded through the base of the braids near the neck to prevent the tubing from catching on obstacles. Horses must be heavily sedated and disturbances must be minimized. If in a busy barn or hospital, temporarily preventing local traffic is important. For sedation, we typically use Detomidine at a dose of 0.02 to 0.04 milligrams per kilogram intravenously. Detomidine will provide a period of sedation of approximately 40 minutes, which should be adequate for placement of the subpalpebral lavage system. The periocular skin and conjunctival fornix are cleaned with diluted 1 to 50 povidone iodine to physiological saline solution. An auriculopalpebral nerve block is performed to minimize motor activity of the eyelid. There are 2 main sites where the block can be performed. 1. As the nerve exits the skull beneath the ear, a 25-gauge needle is inserted to the hub in the depression just caudal to the ramus of the mandible at the ventral edge of the temporal portion of the zygomatic arch. A syringe with 2 to 3 ml of lidocaine is attached to the needle. The syringe is drawn back to check for blood, and if free of blood, the lidocaine is injected slowly. The second spot is where the nerve traverses the zygomatic arch. The nerve can be palpated subcutaneously just lateral to the highest point of the caudal zygomatic arch. The skin above the nerve is tented, and the 25-gauge needle is inserted subcutaneously to the hub. A syringe with 2 to 3 ml of lidocaine is attached to the needle, and the lidocaine is injected slowly. For upper eyelid placement, a supraorbital nerve block is also useful to reduce sensation to the middle 2/3 of the upper eyelid and adjacent skin. The frontal nerve emerges through the supraorbital foramen, located dorsal to the globe. This foramen can be identified by a small depression at the medial aspect of the supraorbital process of the frontal bone. A 25-gauge needle is inserted into the foramen, and 1 to 2 ml of local anesthetic is injected. As the needle is withdrawn, 2 to 3 mL of local anesthetic is also injected subcutaneously in the adjacent region. Additional local anesthetic is then injected along the orbital rim over the intended target site in the eyelid. For lower eyelid placement, local anesthetic is administered along the ventral orbital rim near the nictitans in the intended target site. The ocular surface sensation is eliminated by applying several drops of topical anesthetic to the corneal surface and waiting approximately 30 seconds. Targeted conjunctival anesthesia can be achieved by saturating several cotton-tipped applicators with topical anesthetic and applying these to the conjunctiva at the target site for 30 to 60 seconds. Tolerance to sensation can then be tested by insertion of a gloved finger at the target site. If the horse resents this, additional local anesthetic may be required. For upper eyelid insertion, the clinician must take care to puncture the skin with the trocar at the deepest part of the fornix, just adjacent to the orbital rim. This allows the foot plate to sit high in the fornix and avoids contact with the cornea. If the trocar accidentally catches the palpebral conjunctival during insertion, this will cause corneal contact with the foot plate and result in corneal ulceration. To aid in placement into the fornix, the clinician can use the trocar guide supplied with the subpalpebral lavage system, or may guide the trocar with a gloved finger. If the guide tube is chosen, the guide tube is passed under the eyelid margin and pushed up against the orbital rim. The trocar is inserted through the lumen of the tube and advanced to the target site. For the finger method, the finger is inserted deep into the fornix, and with the trocar lying in the space between the gloved finger and the lid, it is then advanced to the target site. In either method, the trocar is carefully advanced to the conjunctiva adjacent to the orbit and pushed such that it pierces the skin. The manufacturer's label on the tubing near the footplate should be visible about 2 centimeters above the outer skin exit site after the footplate is snugged into the palpebral conjunctiva. A small butterfly tape can be placed above this site to help secure it in place. Insertion into the lower lid requires that care is taken to assure that the puncture site for tubing is close enough to the medial canthus that the third eyelid prevents the footplate from rubbing on the cornea. As in upper eyelid placement, the clinician can use a trocar guide supplied with the subpalpebral lavage system, or may guide the trocar with a gloved finger. The trocar is carefully advanced to the conjunctiva adjacent to the orbit and pushed such that it pierces the skin. Once the trocar has been advanced completely through the lid skin, it and the attached tubing are pulled through the pierced lid. The footplate is pulled snug against the conjunctival surface in the fornix or the cul-de-sac. Next, the tubing and the attachment port are secured. The sharp tip of the trocar can be capped, as this is convenient to use to thread the tubing through the braids in the forelock and in the mane. The tubing is threaded through the braids until it reaches a stout braid near the withers, which will serve as the attachment of the injection port assembly. The trocar is cut off and discarded in a sharps container. A 20-gauge 1 1/4 inch IV catheter is carefully fed into the opening of the tube to create the injection port assembly. The stylet of the IV catheter can be pulled back slightly so that the catheter is strong enough to feed into the tube, but the sharp tip does not damage the tubing. Once the catheter is in place, the stylet is removed. A male catheter cap or injection port is attached to the catheter hub close to the system. We use a wooden tongue depressor wrapped with 2 to 3 4x4 gauze squares as a padded splint for the injection assembly. Lay the injection assembly onto the splint so the cap lies about 1/4 inch from the distal end. Wrap the splint with porous tape to create a wrap that encloses the splint and the tubing but exposes the injection cap. This is then attached to the anchoring braid with tape. The length of tubing that runs from the eyelid to the forelock braid is secured to the facial skin via butterfly stents made of short porous tape or duct tape folded over the tubing. The wings of the tape can be secured to the skin with simple interrupted sutures of non-absorbable suture material. Medication delivery through the subpalpebral lavage system. Injection of medication is accomplished by infusing 0.1 to 0.2 mL of drug from a tuberculin syringe into the cap and catheter with a 25-gauge needle. The medication is then chased with approximately 1.5 mL of air that is slowly injected into the tubing using a separate 3 mL syringe and 25-gauge needle. The air provides pressure that pushes the drug along the tubing and onto the ocular surface. Delivery will be apparent when medication exits the tube, as the horse will usually react by tossing its head, and the eye may tear slightly when the air bolus reaches the ocular surface. Subpalpebral lavage systems can remain in place for several weeks if properly positioned and cared for. Removing the subpalpebral lavage system. Removing the subpalpebral lavage system can be completed in the standing and sedated horse. First, the tube is cut a few centimeters distal to the eyelid exit hole. Remove all wings or sutures that are attaching it to the face. The tubing that remains attached to the footplate can be used as a pole to push the footplate away from the conjunctiva and into the conjunctival fornix or cul-de-sac. The footplate can be pushed enough to appear over the eyelid margin and removed. If it does not appear, a gloved finger can be inserted under the lid to fish for the loosened footplate. The remainder of the assembly is then removed.